Hello, my name is Chelsie Warshafsky, and today I'm presenting a project that I worked on throughout my residency at the University of Toronto, known as the PICS trial, or Preventing Isthmoseal After Caesarean Section, a pilot randomized controlled trial. I have no conflicts of interest to disclose. As we all know, caesarean section accounts for approximately 30% of all deliveries in Canada. An isthmoseal is defined as a defect at the caesarean section scar site of at least 2 millimeters in depth. There's a very wide-ranging incidence cited in the literature, anywhere from 19 to 88%, due to discrepancies in study technique, diagnostic criteria, and patient characteristics. Presence of an isthmoseal can lead to a variety of complications, both obstetric and gynecologic in nature. Evidence shows that a double-layered uterine closure during caesarean section can lead to decreased isthmoseal formation and, in turn, increased residual myometrial thickness. However, no studies have looked at the effects of locked versus unlocked sutures. Surgeons often choose locked sutures with the thought that it is more hemostatic, but this has not been clearly shown. Given their nature, locked sutures may lead to tissue necrosis and impaired wound healing, which may in turn lead to greater isthmoseal rates. We therefore hypothesized that an unlocked double-layer closure of hysterotomy can prevent isthmoseal formation and improve maternal outcomes. The primary objective of this study was to assess the feasibility of a randomized controlled trial protocol amongst our own patient and physician populations. The secondary objective was to determine isthmoseal rates and measurements, as well as any adverse surgical outcomes specifically related to suture technique. We performed a single-center prospective parallel group pilot randomized controlled trial. Eligible subjects were pregnant patients above age 18 undergoing a term primary elective caesarean section. Exclusion criteria involve features that may predispose patients to isthmoseal formation or operative complications. All patients had a standard double-layered uterine closure while being randomized to locked or unlocked closure of the first uterine layer. They then returned for a transvaginal ultrasound at 6 months or greater to assess presence of isthmoseal. All subjects were analyzed on an intention to treat basis. 150 subjects were initially screened, with 122 eligible. Of those, 41 were enrolled, with 20 in the unlocked and 21 in the locked group. With a significant loss to follow-up rate for various reasons that I'll address later on, a total of 11 subjects in the unlocked and 12 subjects in the locked group completed the study. Table 1 shows that there are no significant differences between the groups. Table 2 here shows operative data, of which I want to draw your attention to a few parts. Firstly, the most common reason for caesarean section was malpresentation. Either one Biasin or one Polysor was used, depending on surgeon preference. There was no difference in estimated blood loss, additional medications such as uterotonics, preoperative, postoperative, or drop in hemoglobin, or birth weight. Additionally, no subjects in either group had complications, including retained products of conception, postoperative wound infection, endometritis, or iron or blood transfusions. Primary outcome of the study was feasibility of the trial. In terms of recruitment, 72 of the 122 eligible subjects declined to participate. 40 of these subjects completed a questionnaire indicating their reasons for declining, most commonly citing that they did not want to participate in research in pregnancy, did not want to attend a follow-up visit, or did not want to undergo a transvaginal ultrasound. In order to facilitate follow-up, patients were called or emailed depending on their preference. An average of 2.9 phone calls and 2.5 emails were required, and 12 subjects required rebooking of their initial ultrasound appointments. The biggest barriers to follow-up were childcare concerns and the COVID-19 pandemic, both in terms of halted study activities and fear of exposure. Table 3 shows the ultrasound data addressing our secondary outcomes. Isthmoseal, which again is defined as the depth of greater than 2 millimeters, was seen in 10 out of 12 in the locked group and 11 out of 11 in the unlocked group. Consistent with this, the median sagittal depth was 0.36 versus 0.4 centimeters in the locked versus unlocked groups, respectively. We also measured the residual myometrial thickness, which you can see depicted in the diagram below, and the adjacent myometrial thickness beside the isthmoseal itself, and did not see any significant differences between either groups. I do want to remind you that this is a pilot trial and was not powered to detect these differences with such a small sample size. In conclusion, the study does appear feasible from a physician perspective, as all but one obstetrician was happy to participate. The one individual cited that they were not interested in altering their surgical technique. In terms of patient participation, both recruitment and follow-up are substantial barriers, though the pandemic certainly came into play in this case. Future trials should consider a more convenient and closer follow-up, such as the 6-week postpartum visit. Lastly, a larger trial is required to determine differences in isthmosial rates and measurements between groups. Thank you very much for listening to my presentation, and I would be happy to answer any questions you may have.